why California Healthcare Foundation is supporting this effort, and what the regional collaborative project will involve, and we'll see. And then at the end, we'll have time for questions. My name is Kelly Pfeiffer, and I'm a family doctor and a director at the California Healthcare Foundation. And we're really excited to launch this program. There's a lot of reasons why California Healthcare Foundation has made the commitment to get involved in the opioid epidemic. Certainly at a national population level, we're seeing more and more attention to the fact that the opioid epidemic is hitting us at all levels of society. In California, on average, there's 120 Vicodin prescribed per resident per year. Although we're the 13th lowest across, compared to other states in terms of opioid deaths, there's so much variation in California, and there's regions that are as high as the worst state in the U.S. We also know that opioid epidemic has a profound impact on our medical costs at a time where healthcare costs are a major focus of attention. We know that people on chronic opioids have twice the medical costs than others, and that it disproportionately affects our low-income populations, and that opioid overuse disorder is 10 times as common in Medicaid populations compared to others. And I think many of you on the phone will also say that we're paying attention to this for very personal reasons. A lot of us know friends, children of friends, colleagues that have been devastated by this problem, anywhere from a young kid with a sports injury who starts on Vicodin, is unable to stop and ends up on heroin, or just people taking one prescription from their doctor and making mistakes or not understanding combinations with alcohol or other drugs. In fact, most people who die from opioid overuse are taking prescriptions from their own doctor. So again, this is a problem that affects all levels of society, all classes, and affects us personally as well as making a big impact across our society. So just a little bit of background. Many of you have heard this many times, but I think it's helpful to have the perspective of how we got here. We got here because there was a time when we were under-treating pain, particularly minorities and low-income people. We had intense pharma advertising promoting some, frankly, very bad studies reassuring us that the opioids were safe long-term, they were safe at high doses, people didn't get addicted. And we're now at a very high-risk time because as we realize that those things aren't true, that anywhere from 10 to 30% of people on chronic opioids do end up developing addiction disorders, and we are causing profound harm, even though this situation was created by well-meaning physicians and well-meaning people in the community. We're at risk of going too far in the other direction of people getting cut off from their physicians, cut off from medications when their brains no longer work the way they used to when they've been on chronic opioids. We're at risk of blaming patients, of blaming doctors, and of really creating so much stigma around this. You know, when Dr. Corey Waller has a great quote where he says, if someone goes out and binges on Krispy Kremes and they come in with a sugar that's 4 times as high, we don't cut them off insulin and fire them from our practice. We treat it as a chronic disease that has bad days and good days. Or alternatively, if someone's brain has been changed by opioids for long enough at high enough doses, and physiologically they cannot cope without these medications, if they have a bad day, we quite commonly see people being fired and then resorting to desperate measures without being offered treatments that we have evidence that we know can improve recovery and save lives. So the California Healthcare Foundation is approaching this with the effort to take a comprehensive look at the problem in counties and regions and have different sectors that are affected by the opioid epidemic all work together to create a safe environment. Some of that is safe prescribing, which often means prescribing less. Some of it has to do with being able to identify those parts of our population that have either problematic use or addiction and being able to offer them evidence-based treatment. And a piece of that is saving lives through the use of reversal agents like Naloxone, and also looking at community interventions, which might be take-back programs, law enforcement cooperating with providers. And our goal is to break down those silos where in our current society, addiction treatment doesn't talk to primary care, which doesn't communicate with the hospital, which doesn't communicate with law enforcement, and we're hoping to change that. So what I'm going to do is move forward to some of the logistics of this presentation and then go through the details of the project. I want to introduce Christine Cristobal, who with me will be leading this initiative. We'll be providing project management and coaching. So Christine, why don't you orient us?
Okay, great. Thanks, Kelly, and welcome everybody. So here's our agenda for the next 45 minutes or so. Kelly will introduce you to the Opioid Safety Coalition's, the specific goals and objectives of the coalition. And we'll also talk about what are some of the program elements, the content, the potential faculty, the supports that will be provided to all of the coalition. We'll have some time to talk about the application process and what some of the success sort of criteria and elements are, and help guide you through that and answer any of your questions about the application, and give you some examples of what coalitions have looked like in other counties that may be a great foundation for your coalition. We'll have some time to look at the application timeline, and again, plenty of time for questions from all of you. Just a couple things on housekeeping. We are recording this webinar, so you can feel free to share this with any of your colleagues in your coalitions. All of the materials, the slides and the recording, are going to be posted on that website right there, and we'll do that within the week. At the very end, there's going to be a super brief evaluation form that you will have a link to in the chat. And if you want things emailed to you directly, you can just provide your email there, and we'll make sure to get you anything that you need with respect to the RFP. Please use the chat for any questions. You can chat to me, your host, if you have any logistical questions, and chat to all for any sort of content questions or application-related questions for our speakers. And then finally, again, we'll give you a couple minutes at the end to fill out the evaluation.
And we do have one more webinar scheduled that will be identical to this one for anyone who's going to attend today. Christine, do you have that date available?
No, I'll put it in the chat in a second.
That sounds great. So just going back to an overview, Dr. Andrew Rubenstein, who's a pain specialist, once said that opioids are not bad or good intrinsically, they're just a molecule. So this safety coalition effort is not about making opioids bad. Certainly if I ever go through cancer, I hope that opioids are available. We want to make sure that opioids continue to be available when medically indicated and for palliative care. But we also want them to stop causing the harm they're causing. So we have a stretch goal of decreasing opioid overdose deaths by 30% over 3 years. We know that will be very tough to attain, but that's our ultimate vision of where we'd like to be. And we want to support regional coalitions to implement collective actions. And the Obama administration, through Sylvia Burwell, came out with 3 federal priority areas, and there's many ways to look at the epidemic, but these are the 3 that we're concentrating on in several projects, including this one. The first is supporting safe prescribing practices, and there's many ways that communities can work on that, and we'll go through a couple examples. The other is to expand access to medication-assisted addiction treatment. Buprenorphine is an excellent example that can be integrated into primary care, and that there's many counties where this is not available, and other counties where it's not available enough. And the final is increasing naloxone access. And naloxone, for those who are not familiar, is an antidote. So if someone is found unconscious, that a family member or a friend or a bystander can administer naloxone either through an injection or a nasal spray, and that could reverse death. And we have a recent report from San Francisco where street fentanyl, an incredibly potent dose, street fentanyl came onto the streets, and I believe they had a dramatic increase in overdoses, but no one died, and they attribute that to the availability of naloxone. The way this collaborative will work is peer learning. That we have several counties across the state which have done amazing work in this area, and we really want to be able to learn from those people who are farther along in the journey and learn from people who are just starting who might have ideas that others have not thought of. So we will have some formal faculty from people from San Diego, Marin, Monterey, who've been doing this for a while, and we'll also have the structure to learn from each other. We also find in anything that we do that coaching helps. We wouldn't expect a national football team to get where they get without a coach. We don't expect Olympic athletes to achieve what they do without a coach, but somehow we never connect that with healthcare, and often we find that if you have a coach, someone who checks in with you every month, who helps you work through problems, that you get much further. So that's why Christine Cristobal is going to be working as a coach with the communities. So just a little bit about the three different national strategies, and we will ask each coalition to work in some way on each of the three. And we realize that every community is different, and so that's why we're not being prescriptive about exactly what you do in each of these three areas. We're not being prescriptive about who leads the coalition, because we certainly know that the most effective coalitions are the ones that get all of the different sectors together around the table to try and solve the problem. We will need a lead organization in some communities. That will be the public health department. In other communities will be the medical society. In other communities it might be an interested community clinic or an addiction center. So what the role of the steering committee is not to do this by themselves, or the lead organization is not to do this by themselves, but to empower a group of people working together in task forces to tackle what needs to happen in that community. And again, we anticipate that will vary from region to region. So the first strategy has to do with safe prescribing practices, and this, an example that's very common is getting all emergency departments in a region to agree to a very simple list of safe prescribing guidelines that's been approved by the Association of Emergency Physicians. And several counties, Los Angeles, San Diego, Monterey, have done this over a very short period of time, and have done it both by having the emergency department leadership buy-in, the hospital buy-in, but even including pamphlets about these guidelines that are distributed to patients when they check in, so that they know that everyone is going to be operating in the same way, to use opioids judiciously, to not refill opioids that are a primary care provider's responsibility. The other thing that has been done is having primary care practices agree to a series of guidelines, and having all the providers be on the same page about treating opioids and pain in the same way. I practiced previously at Petaluma Health Center, and this was a difficult process where we physicians don't like to be told what to do, and we resent it when anyone tries to have us operate by a cookbook. But when we worked that way in chronic pain, we found it was total chaos, and that some doctors got the reputation of being nice, and their practice filled up with chronic pain patients, and they quit. At Petaluma, we lost 3 doctors in a few months because of that. The staff were miserable because the rules kept changing, and the patients were miserable. And by implementing evidence-based guidelines across our practice, we found the patients felt they were treated better and fairly, the doctors had better quality of life, and the staff as well. And you'll see that on this page, the very common guidelines that we're seeing over and over in the Medical Board of California guidelines and in large systems across the nation. The first is in acute pain, using opioids judiciously, and being very careful of the 90-day cliff. There have been studies showing that 1/2 to 2/3 of patients who are on opioids 90 days in a row end up becoming chronic users. So helping primary care providers make sure that we identify this early and help get these patients off of the opioids so they don't end up having a problem years down the road. For chronic pain, there's a list of 4 guidelines that we have found over and over continue to float to the top of the list. Avoiding high-risk combinations like benzos and opioids together, and methadone. But most of the deaths that you see, I think it's 30% of deaths include methadone, and another high amount include benzos and opioids. These are very high-risk treatments. To have systems to monitor for and respond to concerning behaviors. To utilize buprenorphine, so that it's a much safer option, and because it's got a lower feelings. In other words, people are much less likely to die from buprenorphine, and it's been proven to save lives and improve recovery in people with opioid use disorder. And also to recognize a high-risk threshold, to not put new patients above 100 milligrams of morphine equivalents or 40 milligrams of methadone. And then when you can, to work with those patients who are on these high doses to slowly over time wean down to a safer dose. And this is very hard work, but again, it's a key component of safe prescribing. Another example of a safe prescribing intervention is EDDI. This is a software program that's used across Oregon and Washington and is now getting a foothold in California. CHCF normally doesn't promote a single vendor, but there's really no one else doing what this does, which is connecting to the electronic health records of emergency rooms and identifying the people who are using that emergency room frequently or multiple emergency rooms frequently, and then being able to, in real time, in a one-page summary, show all of the records, including lab tests, x-rays, and medications. And that this has been found to drop high utilizer visits by 35% and drop ED prescriptions. And ultimately what it does is it helps identify patients who are not getting value from all these visits and to get them into the right treatment where they will get better care, either in primary care or in addiction treatment. And this has been shown to improve communication and collaboration between emergency departments, primary care physicians, and health plan care managers. So anyone who wants more information on this can let us know, but this is one example. Again, many ways you can promote safe prescribing practices, and these are only two examples. And we would encourage you to think about what would work best for your community. I apologize. I just learned that my connection was a little choppy, so I hope this is better. The second strategy is expanding access to medication-assisted treatment. And the main strategy here is not to create opioid refugees, and that's the term that's being used for the people who have been going to their doctor, their body is accustomed to high-dose ongoing painkillers, and then that doctor retires, or the doctor fires them from the practice, or for one reason or another they no longer have access to that. And then unless they have some way to transition to either wean down over time or to go to a replacement therapy, they're at very high risk of overdose and very high risk for having their lives derailed by addiction. So in safe prescribing, we often identify patients who are at risk of overdose and at risk of addiction, and then we need to have a place for them to go. And that's not true in a lot of counties, that we don't have enough access to treatment. And then final strategy is Naloxone, and I gave an example of San Francisco, but distributing Naloxone to either people using heroin, people on chronic opioids, patients and families. There's many different ways to expand access to Naloxone in the community, and that's something we encourage you to think about what would be the best fit in your community. So what are the program elements? The first is convenings. These are mandatory because a key value you'll find in this collaborative is learning from each other. And as many of us have experienced, it's difficult to learn things by webinar. It's much easier to learn things by conversations face-to-face. So anyone who's applying, we ask you to save November 17th. If you do get accepted, we'd like to see your team there. And that will be in Oakland, and that will be a full-day session where we're going to learn from experts from other counties and learn from each other. Then there'll be another convening in September 2016, and then at the end of the project in May 2017, we'll be sharing what we learned. There'll also be periodic webinars throughout the project, and the topics will be generated by you in terms of what you would like to learn and how to share strategies and challenges. We'll have expert mentors. There's physician leaders from San Diego and Marin, and we've included the link to their websites if you want to learn more about what they've done. Again, we anticipate every county may handle this differently, but there are some really good examples about to prevent you from having to reinvent the wheel. There's a coaching element, and Christine Cristobal will be doing monthly coaching calls to help groups develop goals, measures, and action steps. Some people may not need this, and these will be just brief check-ins, and others will find great benefit by spending time with Christine to really help you move the project along. And then for your own coalition, we know that people are in different stages. Some coalitions have already started, and you may have already had a kickoff meeting and gotten going, but that this structure will help you go even further than you would on your own. And so we would want to see in your application how you envision your coalition either starting or getting better because of this structure. So what makes a successful application? We first want to see a strong proposal, a clear plan for either a broad coalition that's in place or pulling together a broad coalition, and a key element is sustaining that over time. We've seen coalitions like Marin get a tremendous amount done with just a short period of a year, but we also know that this is a long haul, and so even though the project is 18 months, we want to see that these task forces and coalitions will last over time. We want to see a lead organization who is able to create some infrastructure. Most people working in this work, it's not their day job, and they're doing it in addition to the rest of the work they're doing. And we won't be successful unless there's some type of infrastructure that may be a half-time administrative person who takes minutes and documents next actions and organizes meetings and tracks metrics and keeps people on target. It could be someone who's managing the web to make sure that as you develop metrics that everyone's on the same page. It may be a project manager who's got the type of skills needed to take a lot of different people moving in a lot of directions and moving them in the same way. And we'd like to, and because the amount of money available in this grant is not that much, it's only $60,000. It's basically up to $60,000 depending on the size of the county and your needs. There will need to be some in-kind support, and that's what we'd like to see in your budget proposal, that along with explaining how you will use the grant funds, that there's some documentation of how the lead organizations or other organizations are really committing to this work. This type of work, because it's work in the medical system as well as outside the medical system, often does not go well without a clinical champion. So we want to see a clinician, and that does not need to be a doctor, but who's got respect in the community and will be able to champion the work, and a project lead, the person who's going to take responsibility for being the contact with CHCF and keeping the work going. This can be the same person or different people. We'd also like to see broad sector commitment, and we realize that it may not all happen between now and when you submit your application, but we do want to see that you're making a commitment to get letters and commitment from medical association, public health, or the county delivery system, clinics, health plans, hospitals, emergency groups, addiction treatment, law enforcement, that you do the best you can to get the broad group to the table. And if you don't have someone at the table, we'd like you to help us understand why not. Is it something that's in process? Is it something that you can work on through the course of the grant? And if we have more applications than we have room for, we'll be taking into account geographic diversity, severity of the epidemic in that community, and the number of residents impacted. So for example, smaller northern communities may have much higher death rates, while larger urban communities may have much more residents impacted, and we'll be taking those factors into account. We also know that there is so much benefit from learning from others that we've created 2 tiers of grant awards. Although we only have room for 10 coalitions in the Intense Collaborative, we do want to offer the opportunity to learn from each other for others who don't get into the collaborative, and that will be through reimbursing travel and inviting people to the November convening and the final convening, so that there are opportunities for people to learn even if they're not going to participate in the more intensive collaborative. So this slide is an example of a comprehensive approach that there may, as you develop your steering committee, you may have a prevention and education task force, a surveillance task force that works on the CURES program, and an diversion control or law enforcement, licensure, and treatment and recovery. Again, this is one approach that we don't anticipate everybody to take. There's another approach that that Marin County has used, and I will emphasize again, we're not expecting every coalition to follow this example. Marin County is an example of a relatively early coalition, but that has done a great job of putting everything on the web, and it's got a very nice organizational structure. So it would be worth looking at how they organize themselves to see if this is something that would work for you. So they have a steering committee that has representatives across education and different partnerships, and then they have 5 different action teams working on different parts of the epidemic, and each action team sets themselves a goal for the year and sets themselves particular metrics to work on that goal. And it's worth looking at their website, RxSafe Marin. So again, if this applies to you, you don't have to reinvent the wheel. Another thing that Marin has done, which I thought was interesting, is look at the life of a pill and then think through in your community, how do you influence each stage, from manufacturer marketing, which you may be able to tackle or may be outside of our control, but prescriber certainly is an area of a lot of attention, pharmacist, the community, working on disposal, unsafe use,
in any case, seeing in your community where the epidemic is coming from and looking at each place that we can impact it is another approach. And again, from the website in Marin, if this is helpful, there was an example of how they did launched their coalition in case this is useful for people just getting started. What we see very commonly is a community kickoff meeting where data can be shared about how that community is doing with prescriptions, deaths, and ED rates. And all of this data is available to you in the RFP, and we'll continue to provide data through the California Public Health Department and CURES. And then after that community-wide meeting, forming work groups, and then continuing to keep the community involved through web publications and through future community meetings. Again, these slides will be available, and you can also look on RxSafe Marin. So I was told that I'm breaking up, and I do apologize. If there's anything that you haven't been able to hear, feel free to speak up when we do the Q&A, or you can use the chat function. But I did want to say again, we will have two types of grants. There will be 10 coalitions that will be either county or multiple counties and regions. So 10 of these coalitions will be funded and will receive the $60,000 to support administrative support, will receive coaching, and will be a part of the intensive collaborative over time. And other communities who have good applications but for one reason or another are not part of that 10, could be also because of geographic reasons, we will invite you to the initial kickoff meeting November 17th and to the final meeting, and that will be more likely to be a half day so that you can learn from these other counties that have done this type of work and have a chance to network and share strategies. So the timeline you'll see in front of you, the October 11th at 11:59, we're being strict about that to make sure that we have enough time to review them. We want to see the application and letters of cross-sector support. And there's more details about what that application is and the letters in our website. We'll announce the participants on the 26th and have a kickoff webinar that's an orientation webinar on November 3rd. And then we'll have our mandatory convening all day on November 17th and a half day for those who are just participating in the learning sessions without the whole collaborative. We'll have webinars and the midpoint convening and in-person closing convening sharing our results will be at dates TBD. We'll work with the teams to make sure that we choose a date that works for you. So at this point, we're going to open up the lines for any Q&A, and you're welcome to use the chat function for the Q&A or just speak up.
Hi, Kelly.
Yeah.
This is Della from Orange County. I have a couple of questions for you about the use of data. In the packet, you have data that comes from places like OSHPD and some other resources. Will we be able to use our own data to develop the packets that we'll send off to you?
Absolutely. And again, I want to clarify that anything that is not mandated in the application is absolutely discretionary. So in the packet, we have given you comparative county data that comes from CURES and comes from the Department of Public Health. And this data will be updated and available to all counties over time, even if you're not participating. The dashboard that we took from Marin was just an example. It was what Marin used and they developed that internally to give them an idea of how they were doing over time with their interventions. And we anticipate that every region would do the same and would do their own dashboard. It was just used as an example.
Well, then I think I must be mistaken because I'm referring to the 6 or 8 pages worth of statewide data, not the report card, because in Orange County and San Diego, I know we both have report cards that we use. I'm referring to the data that listed 6 or 7 pages. For the
so that data is for your own use, and so that we recognize that any time I'm sorry, if you're not speaking, if you could put yourself on mute, that'd be helpful because there's a lot of background noise and typing. That data is for your own use. For example, if you wanted to do a kickoff meeting or an update meeting and say this is how we're doing compared to other counties, you're welcome to use that data. We also know that every data set has limitations, and that some data sets are more limited than others based on how county, coroners, code, deaths, and the very specifics about how ED rates are counted for opioids. So this is for your own use. If you have a local, better data source that gives you more real-time information about how you are doing, and of course, Orange County, you've been doing this for a long time. You've got some robust data metrics that you've developed. Great, use those. These are only meant to be useful in case you are starting from scratch.
Thank you.
Kelly, I have a question from the Q&A. It's from Haziah Williams, and the question is, for the cross-sector commitment part of proposal, are any specific organizations required to be included in the applications coalition?
I wouldn't say that they're required, but I guess I would say that there's certain organizations that have been very pivotal in other counties. And so, for example, if your medical society is not involved, or if you have a large county delivery system and they're not involved, we might raise eyebrows about whether this is a very strong coalition. So I would look in your own community and see who are the big players and do your best to get them at the table. And if you can't get them at the table, then help us understand why. And we certainly won't, we aren't seeing any particular organizations required. We do know, though, that in any community, there are often different organizations that will step forth. And that's why we specifically said that we only want to get one application per county. We know that certain counties may band together and do one together. But what we didn't want to see is a medical society submitting one application and a public health department submitting another application, because it's really important for those two sectors to work together. So that's why I would recommend thinking about the usual suspects, who in your community is likely to lead, and reach out to them. And if you are struggling with that, you can email me and I can make any connections if there's people that I know about. And if we do end up getting two applications from a region that didn't know about each other, then we'll do some matchmaking. But it would be much easier to do this on the front end. Again, in summary, no required organizations, but the strongest applications will have broad representation.
Hello, Kelly.
Yes.
Hello. Kelly, can I ask you, can the purchase of the Naloxone be included in the budget?
You can use the budget any way you like. What we just want to see is that if you use the budget to purchase Naloxone, that you have another way to meet the administrative needs. So if you have in-kind project management, an in-kind clinical champion, an in-kind clerical support, you can just let us know how you want to use the funds. We don't have it.
Thanks.
Other questions?
Hi. Yes, I have a question. You mentioned geographic representation. So in hearing that, does that mean that you'll be looking, or the grant recipients would be favored to more of like a urban, highly populated area? My area is actually part of the Central Valley, which has a huge issue with opioids, and actually has had some issues with physicians themselves in terms of their prescribing habits, where we've had some physicians being disciplined as of late in the last couple of years. But concentration of actual, it's a county of about 500,000, and so, right, but it's not an urban.
Yeah, so what we mean by that is that if we have 12 applications and 10 of them are from the Bay Area, then we're going to be looking to try and increase geographic diversity. What we'd like to see is a coalition that represents the state, that we have Southern California, Northern California, urban and rural, the Central California is represented. So what it means is that we'll be looking at the applications entirely on their own merits, and then when we get the finalists together, we want to see that there's some diversity.
Okay, great. Thank you.
Are there other questions?
Kelly, here's a question. Regarding the request for in-kind support, where on the line item budget form should we put that information? I don't see an area or column on the budget that makes it clear that the personnel item is in-kind.
You know, if you can give us a minute, let me take a look at our form. And actually, rather than do that in the moment, I would say just use the form in a way that makes logical sense, and I'll take a look at the form after the webinar. And if there's not a section for in-kind, we'll make sure to add that. But I've seen these types of budget narratives that included both in-kind and grant, and so there is a way to do it within the current form. But if your name is on that question, we'll email you personally, and we can also just take a look at the form and make sure that it makes sense intuitively.
Yeah,
so
I have the person.
Thanks for bringing that up.
Kelly, I have a question for counties that want to apply together. We work with counties up in the northern region that are quite small, and there's one county that is leading the effort more than the others, but they want to apply as a group. So the way that it looks now is we're going to have representation from the different counties on the coalition, but the lead is in one county. Does that sound okay, or does the lead need to be an organization that's in each of the counties?
No, I think that what we'd love to see is cross-county collaboration, and a very strong application would be counties working together. And we know that there's a sweet spot between the coalition being too large to be effective or too small, and so we anticipate that the people who actually live there and working in that area will know that sweet spot. So counties coming together to form a region will be strong, and we're certainly very happy about that because it allows us to cover more of the state. And of course, if the lead organization is one of those counties but is working collaboratively with the other counties, that's great.
Okay, great, thank you.
Other questions? Christine, anything else that you've gotten in writing?
So far, no other questions in the chat or the QA.
Okay, so as we mentioned,
can you hear me?
Yes.
This is Amy. I do have some questions in the chat, but they haven't been answered. So can I go ahead and ask them?
Please do.
Okay. Can any type of organization apply for this, or do they have to meet specific criteria? Like, can private nonprofits apply, or should it go under like a county? Okay.
So I'm going to actually go back to the criteria. So the strong lead organization, the criteria are clinical champion or project lead. Again, can be the same people or different people, and then enough infrastructure to hold together. So we'd see a very strong application would be an organization that's doing in-kind support indefinitely. So we don't have any requirements about who that lead organization is.
Okay.
But thanks for asking.
Is there an evaluation piece?
There is, in that we have, this is the issue with the evaluation, is that this is an 18-month collaborative, and that there's typically an 18-month or 2-year lag to report opioid deaths, and there's also a bit of a lag with prescriptions. So what we will be tracking per county and across the state, prescription rates, death rates, PD rates, hospital rates, but it's going to be tricky to actually attribute changes in that specifically to this particular grant, because at the same time we're doing this, there's a lot of other work happening. So we aren't going to be doing a research-like, robust, very expensive evaluation because there's just too many complicating factors. But we will be collecting lessons learned and publishing those, and we certainly will be tracking the trends in the data for prescriptions, ED rates, and deaths, and reporting that, working closely with the California Department of Public Health over time.
Thank you.
Sounds like Stephen Linder from the VA. Oh.
Okay, let me say one quick thing on the evaluation. We do encourage local coalitions to do their own constant learning. So the more a coalition says that we've got our goals, we've got metrics, and we're tracking that over time, we feel like that is far more powerful than something that we would do globally. All right, I'm sorry, from the VA, go ahead.
Hello, can anyone hear me?
Hello. Yes.
Yes, I'm Steve Linder at the VA. First of all, the California Healthcare Coalition, the Twitter site, but is there going to be a specific hashtag that's going to be associated with this project? I find working in social media portals to be very helpful in this type of endeavor.
Wonderful idea, and our communications department will be delighted that that was proposed. So yes, we'll make sure that happens.
Okay, thank you, because I'm very interested in coordinating Naloxone distribution programs specifically with professional first responders. Secondly, my VA facility seems to be blocking access to the evaluation portal. It often blocks Google Drive documents. Can I access it?
Christine, yeah, can you send that link to people by email?
I'm sorry, could you repeat that? I was looking through the Q&A.
The evaluation of this webinar is being blocked. So I think the other way to do that, since this is really an informal evaluation, we just want to know how this works and if there's anything that we can do better. Is just if you have feedback for us, you could also just email us. But if anyone does have access to the formal evaluation, it's very helpful if you just fill out, I think, just 3 questions to let us know what we could do better next time.
Well, I copied the address. Hopefully off-site I'll be able to access it.
Okay, great. Thanks so much.
Yes, I pasted the evaluation link into the chat so people can get it that way. And then also there were just a couple of questions about the recorded webinar being available, and yes, that will also be available. And the chat, there is a link to that as well, and I'll paste it in again so you have it right near the end of the chat.
Thank you.
And then Christine, did you get the date of the second webinar?
Yes, the date of this, it's September 9, 2015 from 12 to 1 p.m. And I'll paste that again at the end of the chat so you guys can see it right there with the link to the WebEx.
And this will be an identical webinar today, and you're welcome to call in again if you have particular questions, or encourage colleagues to call in or listen to the webinar from the recording. Any other questions? Well, again, I really appreciate your time, and we've been delighted by the interest that this proposal has generated. I apologize that there was a little bit of choppiness from my speech on the speakerphone early, so if there's anything that was not clear from the earlier webinar, do please feel free to contact us, and we'll be happy to take questions by email. I think we'll close the webinar today, and again, thanks for joining us.
Thank you.
Thank you.